iEcho session, which is a patient blood management session, which, as you know, happens every month or two. I suspect a couple more people will be joining us because there's a slight change to the registration process, which takes a little bit longer than usual. And for that reason, people may be joining the room a little bit later than usual, but once it's done, I think for the next time it should be fine. So just to remind everyone, these wonderful sessions are co-hosted together with the University of New Mexico in Albuquerque. We say thank you to Prof. Chris Kasianides, who's very much involved in getting these meetings going and sustaining them, as well as Cheryl Valentine, that helps to do the logistics and organizing around the meetings. So thank you very much. There are about 300 people in total that are involved with these meetings from all over Sub-Saharan Africa and beyond, mainly Sub-Saharan Africa. And yes, so today we've got a very interesting and unusual topic, but one that I do think has important and interesting implications potentially for patient blood management. So I met recently with Dr. Gary Sudwarts, who's with us today. And Gary is an interventional radiologist from Cape Town. He works all around the country. He seems to be flying wherever he is needed. But mainly, from what it sounds like, Gary, you can correct me, Cape Town and Johannesburg. And he's done some very, very interesting work in embolizing uterine fibroids, which, as you know, is one of the major causes of blood loss in women. And Gary has the largest series of patients in the world in terms of this procedure. And so, Gary, it's really a great pleasure to have you with us. And we look forward to your talk. He has also promised to say a little bit about other types of embolization as well. But the focus here today will be how can we stop bleeding? How can we save lives? And what I'm very excited about for Gary to share is some techniques that could be used in places with no money at all. So I will leave it at that. And just to gauge or to get you a little bit more curious, and at this point, hand over to Gary to share his screen and take it further. Thanks, Gary.
Hi, thank you. Thanks, Brendan, for a very kind introduction and welcome. And I have been asked, so initially was to talk about fibroid embolization, but I've expanded it slightly because the second speaker, so I've got about around 40 minutes, I guess. But what I'm going to do is I'm going to walk you through the advances that we're into. I hope you guys can share, can see the screen that I'm sharing now. Is that obvious to you?
Yes, we can see it.
Okay, fantastic.
And just for those in the audience, please feel free to add any comments or questions to the chat while Gary is talking. Thanks.
Great. So what I'm going to do is I'm going to walk you through sort of advances in embolization specifically, because that's sort of most interesting to you from a blood management perspective. And then I'll take you through a little bit of details in our specific practice. Let's get the next page going. All right, just to give you a perspective on how big this very, very sort of specific niche is, this is an invitation to the latest meeting in Valencia to be held in June. This is called embolotherapy. It's a branch of CSIR, which is a branch of the European Interventional Radiology Group. So pretty much radiologists have split into interventional radiologists, and then there was another split into embolizers. So this particular meeting has 114 lectures over 3 days, 106 faculty attending, and it's got a vast bunch of ideas that are being spread. So I'm just telling you that this is a really exciting niche in interventional radiology. It's going to have impact on lots and lots of specialties. To give you a perspective in Africa, my impression, and I don't have specific numbers, is that Egypt kind of leads the way right now in terms of skills and availability in interventional, followed by South Africa. Nigeria is busy. And then Kenya has specific links through their academic groups. Other countries are also active, but that's pretty much the top four. Within Africa, we have our own groups. So South Africa, we've got Saints, which is our professional grouping, and then Sapphire is the African version of that. And we linked very, very closely to European and North American societies. What I'm guessing is that interventional radiology is going to be its own specialty very, very soon. You're not going to go past radiology. You're just going to go straight into IR from medical school. That's the North American experience. And I think it's going to spread to Europe and on, because the skills really are very specific to our specialty, and you don't need all the diagnostic knowledge to be able to do the procedures. So this is kind of a very busy slide. I'm just trying to show you that the impact is on lots of areas. So within gynae, we're doing fibroids, adenomyosis, PPH. These are big bleeding conditions, urinary hematuria, aneurysms, prostates for benign prostatic hypertrophy, musculoskeletal for pain and hemarthrosis. So these are just specific interventional indications that relate to bleeding. Oncological, so we're doing TACEs of the liver, that's chemo embolization, and palliative care for patients who are bleeding. GI, BRTO, so that's for varices, GI bleeds, upper and lower. Neuro, so that's a very big specialty of its own, which is aneurysms, meningiomas, angiofibromas, specifically to the bleeding side. And then vascular endoleaks, aneurysms, trauma, we're seeing lots of penetrating, non-penetrating trauma, and then pulmonary bronchial. And I'm going to show you specific cases from our practice that may interest you. So when we do what we do, we need some equipment. What I'm showing you is kind of the very basic level of equipment we would need, which is on the left, the mobile units. That would be like a high-end C-arm, a little bit higher than most hospitals would stock for orthopedics or urology. So this is like a second from top device, something like 4 million rand. And then all the way on the right would be a dedicated interventional unit with 2 C-arms. We use this in some of our hospitals, and that's like, I don't know, 25, 30 million rand. So you can get away with the minimum on the left for emergency cases. You could do quite a lot. And those images are getting better and better. You don't necessarily need to have this really dedicated, expensive suite, although it does expand your options. What I want to show you here is an actual procedure. So we pretty much use the radial artery now for all of our interventions. And I'm going to play you a quick video just showing a uterine embolization. So here we're giving local anesthetic into the wrist. We're passing a little wire, Seldinger technique. Sheath goes into the radial artery. Now we pass a catheter through down the arterial system with a map of the patient's arteries. That's the uterine artery that we guided into. A microcatheter is advanced into the uterine artery, and these are the particles that we will inject. So the whole uterus will become ischemic. That'll cause necrosis of the fibroids, and they'll shrink and die. And the patients, so that we withdraw the sheath, pressure from a cuff, and that's before and after. So I'll take you through some details of this procedure. So these are just kind of range of embolics. So we're talking about ways of blocking arteries. So from the very cheapest, most available, it's things like a gel foam. This is really surgical foam that we cut up into little pledgets and we mix into thick slurry. We can inject that, and that causes a temporary, maybe a few weeks, a blockage. We could put in coils, lots of different ranges of coils, range in size and expense, but effectively the plan is to block an artery in a safe way without the coil sort of going somewhere you don't want it to go, or going forwards or backwards. And this is the last one is a very interesting technique advanced by a guy called Vidal in Marseille in France. And what he's discovered is that you can actually use almost anything to block an artery. So here he's using a nylon suture. And this is particularly applicable to developing countries where you could literally just pass a piece of nylon that you cut off, obviously the needle, and put it into the catheter, push it down the guiding catheter, and you can create a embolic, endovascular embolic with almost no cost. And that would be available. I mean, that's part of, cost is one thing, but availability is another. These particles or coils, whatever they expire, they have to be available in certain sizes. And if you're doing this, in multiple places, quite a challenge. So this is quite a clever way to resolve it. So he's pushing this thing he calls fair embo. So one of our issues is supply. So that means trained people who are able to do embolization throughout South Africa or Africa. And then part of that problem is demand. So we need clinicians to think about us and call us when they need us. And it works both ways. So meeting, talks like this expands the horizon. You guys will have the problem and call the radiologist, and hopefully we'll meet that demand with the supply. But we have responsibility to train specialists, and we do that through the universities and our societies doing symposia and special skills training. And really what we're trying to do is improve morbidity, reduce mortality, and I guess, sorry, this is from my fibroids talk, improve fertility. I'm just going to show you a case now. So this is a patient I was called from a Grooteskeer 10 o'clock at night. So what had happened is 10 days ago, she'd had a baby. She's only her first baby. And she came in with sepsis, and they pulled out what they thought were retained products. She continued to bleed. And then they packed her. But this whole long process resulted in 10 units of blood being transfused, and still she was very, very shocked. From my perspective, it was very easy. I went into I did an angiogram pelvic arteries, as you can see in the top picture, and that arrow is pointing to a blush. So that's extravasation of contrast. It's very easy to see without all the packing and the blood and the tissue from our side. And I find invariably that it's always the uterine artery that's bleeding in these conditions. The gynaes always check them very, very well, and they always don't see them. I mean, they wouldn't call me if they did see that it was bleeding. It's because it's oozing. But with our pressure and our very selective approach, it's a lot easier to make the diagnosis, and to block this artery is technically not that difficult. So we can put in a number of things. In this case, I used coils. And it blocks the bleeding immediately. So it results in the patient stabilizing in front of your eyes pretty much. So I'm going to talk about uterine embolization. So this was performed first in 1995. Since then, there have been hundreds of thousands of cases worldwide reported in various series. It's gone through every major validation of gynae groups, radiology groups, and funding groups. And so it's covered by all the medical aids in South Africa now. And effectively, it's about 40 minutes of the patient being sedated. Yeah, it happens in hospital because we need to last through the first day. The patient's very, very sore. She's got a massive organ that's ischemic. So we need one day to get her comfortable. And then she'll go home with no scar, no cuts. Within 7 days, she'll be back at work. And I'll show you, sorry, this is an unreferenced, I didn't have time to go through all the studies, but trust me, it significantly reduces blood transfusions, ICU and hospital stay. And that's from the Royal Colleges and all the rest. I can figure out those references after the meeting. So this is effectively the procedure. We go in from the radial artery down the aorta into the iliac arteries, and the uterine artery is usually pretty big in these patients because they've got big uteruses. And the genius is that we don't have to go to each fibroid and embolize it individually. So if they're 1 or 100 fibroids makes no difference to us. We simply inject the particles at the level of the transverse portion of the uterine artery. And those particles will be totally non-selective. They'll block all arterioles of that size. But because the uterus has such exquisite collateral supply, it lives, and the fibroids will die. So the uterine artery will be open in a few weeks' time, and the fibroids will shrink to about half. So what you'll find is 90 to 93% patient satisfaction at 5 years for bleeding and pain. These patients very rarely need to undergo another procedure, maybe 10% for, and they could have another embolization or a hysterectomy or whatever. But that's compared to a recurrence rate of fibroids in myomectomy of 70% at 7 years, and a complication rate that's said to be somewhere between 10 and 14% for hyst or myomectomy. It might be a bit high, older numbers and pre-laparoscopy and everything, but uterine embolization is 1 to 2% complication rates. I'll show you my own numbers now. So this is very interesting. This is adenomyosis. It's very, my experience, very underdiagnosed condition in South Africa because we don't do enough MRIs. So it's a very easy diagnosis on MRI, not a great diagnosis on ultrasound. So our reliance on ultrasound, because it's cheap and available and all of that, lets us down a little bit here. So adenomyosis is where it's effectively endometriosis of the uterus. So the lining of or cells of the uterus that should shed every month have grown into the muscle, and they are hormonally sensitive and bleed and swell every month with periods. So patients are, have great morbidity. They might be in bed for days of a month, and they just want the uterus out of them. What we're finding is patients who diagnosed with fibroids actually have either adenomyosis or mixed disease. And so therefore, myomectomy would not resolve this problem. What you've got on the left is bad diffuse adenomyosis. What I hope you can see my pointer. You've got a white line of the endometrial stripe, and you should have a dark gray line over here, but it's actually, you can't really make it out from the rest of the uterine muscle. And that junctional zone is just gone. So that makes the diagnosis for us. In this case, you've got focal areas of adenomyosis and fibroids mixed. Typically, angiogram looks quite different from fibroids. We can see this typical corkscrew appearance of the arteries of the uterus. That's just, again, a feature of adenomyosis. Showing you another case that we could treat. This is a patient with very, very severe rectal bleeding. Patient, walking around, and then suddenly there's this gush of blood. It's the hemorrhoids, and we can embolize the rectal arteries. So hemorrhoids, of course, dilated veins. But if you block the arteries that supply the veins, you effectively cut off the head of the river, and you can reduce the pressure in the hemorrhoidal veins. And these patients do very, very well. It's a quick sort of low morbidity procedure to block the superior middle rectal arteries to reduce the venous pressure. This is a case of HHT. So we don't see them that often, but we're one of the only sort of practices that does do this procedure, where we'll go in from the femoral vein through the heart into the pulmonary artery, and then you'll see an AVM. The problem, of course, is that this vein drains into the heart and then back up to the arterial circulation. So any embolic could land up in the brain or elsewhere. So you've got to be very secure in positioning of your selecting your embolic device. So it's very well fixed in the feeding artery and well positioned. So these patients, you might do them a few times, take them off over in a few events. We're trying to prevent, obviously, the stroke or other complications of these AVMs. So here we've got a patient with a great big bunch of dilated pulmonary veins in the right low segment, and it's an angiogram of the same patient where we've selected out the pulmonary artery that's feeding the vein. You can see this great big vein rushing back to the heart. And here's the before and after pics. So we've selected out that specific segment of pulmonary artery and actually put a little plug. This looks like a basket. It's within the catheter is very, very thin. When it comes out, the alloy makes it expand at body temperature, and this sits absolutely beautifully in the pulmonary artery and has blocked that vein completely. So that's HHT. Forgive me, this has actually not been, there's a little bug. This is joint embolization. We've just started doing this. This is for pain, arthritis specifically, where we can perhaps slow down the need for a joint replacement. So you still might need a joint replacement, but if we could buy you a few years of pain-free, that's the plan. And we've just started doing this with UCLA. Right. This is just kind of a show of bizarre case. Obviously a dog. So here we've got a case where the vets called us, and they called us because they called the liver surgeons who said, we don't work on dogs. And then I couldn't figure out how to take a dog into my private hospital in Cape Town. And they said I should do it at the animal lab at GCT. And the animal lab said that I can't do it there because I haven't got ethics. And I couldn't understand why I need ethics to operate on an animal if the parents said it was okay. But despite that, I managed to convince the powers to bring the dog in the late at night, and it was really pretty stressful, but we managed. So this is a case of a patent ductus venosus, which is not uncommon in larger animals, and you want to block it while the dog is not quite developed, so that they don't develop portal venous hypertension. So that's the dog after, and she's got a bit of a patch on her neck where we access. It takes quite a team and a lot of advice when you do a case like that. So just a little bit about us. We are just dedicated interventional radiologists, specialized, practicing in 4 South African cities. That's Cape Town, Johannesburg, East London, and Umhlanga. We pretty much go where the cases are. So we mainly doing elective cases in booked lists. And we particularly specialized in embolization and also interventional oncology, affiliated to UCT and to Wits. Just want to show you kind of what we do. Around about 450 cases per year. Apologize, I've got a background noise here. I'm just going to try and close a window. Okay, that might reduce the noise a little bit. So we do around 450 cases a year. 2 dedicated interventional radiologists. We work with a close team of specialists. So what happens is the patients will be referred to us, or they'll come to us directly, and then we'll refer to a specialist for a second opinion, because we need that specialist interaction between us and the patients rather than the direct route. And what we found was in our own cases, we had a 54% instance of adenomyosis or combined adenomyosis on patients who had MRIs were referred for fibroids. Just shows there's a very large incidence of this condition, which is underdiagnosed. And then our own practice complications. So again, it's unpublished data, but in almost 1,900 consecutive cases, our major complication rate was 2.1%. So that's anything that brought the patient back into hospital within 30 days. Talking about from PE to ARDS or infection or pain or headache or absolutely anything. So that's pretty low. We've had 32 pregnancies in 30 patients. So these patients were all told they couldn't have babies, they needed surgery or refused surgery. And that's why they had embolization. So it shows that embolization, you can get pregnant after embolization. 3 miscarriages, which is not very high, and a amenorrhea rate of under 1%. So what we've also found and agree with our colleagues overseas is that there's really no size or location limits on these fibroids. It doesn't matter how many fibroids you got, or whether it's submucous or subserous or whatever, it doesn't matter, because this huge mass of necrotic tissue doesn't get infected. It doesn't complicate. Theoretically, we were limited because, why would you want a 5 kilo fibroid just dead in your belly? And the reality is patients kind of thank you afterwards. It gets small enough for them to be happy. We haven't had the need for transfusion within a procedure in all of those cases. I mean, that's logical because patients don't bleed. We're going through a small little artery. This is kind of where we converge. So I was approached many years ago by Jehovah's Witnesses, and they were obviously very keen for us. Well, they're sending us patients specifically because we don't give blood. So they're very happy with us. But what occurred to me is that they know quite a lot about sort of non-transfusion therapy. So I asked them to send me their formulas. And this is where I would love your opinions. So what do we do with a patient who has extremely low hemoglobin, who's clinically quite stable? The reason is iron deficiency. Can we give, like super doses? Can we pump them up in hospital? At the moment, we're giving a lot of IV iron during admission because that's kind of convenient and cost efficient. But I'm thinking maybe we could do a little more, like, folate, B12, erythropoietin, whatever. And I don't think anyone's specifically looking at these patients. Hemoglobins are like 7 or 8, and it's been going for years. Can we give them that bump while they're with us? And that's pretty much it. I hope I haven't gone too fast.
Thanks, Gary. That was really, really fascinating. And I'm going to ask everyone, if you have got any questions or comments, please put them in the chat. But maybe, Chris, can I ask you just to give us your thoughts after having seen this?
No, I mean, this is just the most amazing thing, particularly for our continent. I mean, from a cost-saving point of view, but complication rate is low, seems pretty easy. I mean, there's a bit of morbidity afterwards, as you say. You've got an ischemic organ, but that doesn't seem to be a bit detrimental. And no, I can only see advantages. The only thing is, if you want to broaden it into the continent, you obviously need the radiological facilities. And as I noted, there are only three countries that are Cairo, Nairobi, and Cairo, Egypt, Nigeria, and Kenya.
I mean, Egypt is far and away. They're kind of independent of Africa.
I agree. Yeah.
In this context, so they don't even talk to us. To be honest, they're just so far ahead. There are hundreds of them, and we would be in the tens. But Nigeria's moving fast, and then Kenya's got this link to Yale, or sort of East Coast universities in the States, and then also to Aga Khan and India.
So we've got a big network in Sub-Saharan Africa. And so if you're ever interested, please contact us through GASO, the association that we run. But I agree with you. We are Sub-Saharan. We work Sub-Saharan, but we think African. And I agree with you. Don't feel out that Egypt doesn't talk to you. They don't talk to us either.
Gary, you mentioned the bleeding varices in which instance would you prefer this technique over the normal endoscopic techniques to manage bleeding varices?
I think when it fails, so that, first line is going to be your banding and that kind of thing. So just your normal techniques. Well, what we offer is BRTO, where we effectively go into the adrenal veins and we access the esophageal gastric varices from the bottom, and we'll feed in foam to block them. So it takes a fair amount of experience and skill. It's only really offered, I'd say, Donald Gordon and in Cape Town at GCT, perhaps in Bloem. Sorry, I've actually will be also offered in Durban. But really at the major centers.
So clearly, it's not, I mean, you need to control the varices endoscopically, and this would be for the post-variceal.
Yes. You get the complicated patient, exactly.
And the risk of thrombosis post these procedures?
Pulmonary or which?
Sort of, let's say you do stop a variceal bleed.
Yeah.
Or you do a uterine fibroid. Do these patients with all this necrosis, inflammatory masses, do they tend to have an increased risk for pulmonary embolism, venous thromboembolism, anything like that?
I think it's reduced as compared to the surgery. I mean, you'll find all your markers will be through the roof. But we've had 2 PEs in those 2,000 cases, and both were patients that traveled far. They went back by taxi to Butterworth and to Swaziland. So what happens is, because our patients have a radial puncture, they're walking, going to the loo within 2-3 hours of the procedure. So they really are up and mobile. We don't give them we give them heparin in the procedure, but we don't give them Clexane afterwards, no matter what their weight, as long as they're moving. So I think that the risk, well, I'll show you, the risk is vastly less than surgery.
Sure. Yeah, the other situation where one gets difficult to manage bleeds would be with these newer or direct oral anticoagulants, where reversal agents are not necessarily available, and patients may be bleeding, and it's very difficult to stop sometimes. Surgery, hard to do because they tend to bleed even more. That would not be a contraindication for you, would it?
Would that be a GI bleed?
Yeah, let's say let's say a GI bleed, for instance.
Sure. Yeah, not at all. So our standard guideline is INR like 1.4. I know it's not a great measure, but the fact that we can see what we injured, because it's radial artery, we can see if there's a hematoma there. We can stop the bleeding just with pressure. Finding the source of bleeding is a separate issue. That can be complicated and difficult. And you'd go through your standard sort of CT and nuclear medicine and then radiology to find these, and it may not be easy, but certainly we're offering options that are much less, and also logically, I mean, you're in that tiny little artery, you can block it with great effect. We're talking about like rectal bleedings and GI. Yeah, it's a super option.
Okay, fantastic, great.
Thank you.
Let's just hear anybody else with any comments or questions.
Did you just want to elaborate on the pain after the procedure?
Yeah, sure.
Thanks.
Okay. So I won't lie. It's usually best not to, because patients, you under promise and over deliver, so they expect pain there. It's usually better. I must say, it's impossible to predict big patients, older patients, a size of fibroids. None of those seem to indicate to me why someone would be sore or not. And sorry, all of our meetings end with someone asking, how do you manage pain? So like, in the radiology meetings, no one's got a particular plan. What we've got is a mixed protocol. I do a pain block after the procedure. So we put a long-acting local into the hypergastric plexus during the procedure. So it's another little puncture through the abdomen. We go through all the organs of the abdomen with a thin little needle and deposit ropivacaine into the hypergastric area. And that kind of takes 2 points off the scale. And then we use all the opiates and non-steroidals and paracetamol. We give them absolutely everything. And it all sort of helps, but they go through a phase, and the next day they're fine. The next day they're ready to go. So for me, it's just about getting through that ischemic phase where the blood's going back. You need to get those 8 to 12 hours under the belt. Having said that, in the States, they don't admit them. Patients go home with oral opioids and good nursing follow-up. And I think that's because they're just told it's going to be $4,000 if you stay here and $400 if you go to the hotel. So they're happy with that. And in Germany, they keep them for 5 days for pain management. So I think it really is like a sort of population-specific thing.
Gary, what are the sort of frontiers of embolization therapy? What are the things that that are still a challenge and that you hope to overcome? So what can we expect going forward?
So you see specific barriers to entry which are popular so for instance fibroids are very, very hard to take off anywhere in the world. That to be fair, gynaes ran the place. They were very hard to convince, but in places with national health services that the gynaes were prepared to let someone else in, they saw amazing results. So that took sort of 25 years to come through. We've seen the same with prostates. So you got huge numbers of prostate embolizations being done in some areas. And why would you want to go through a TURP? But the urologists say they don't do TURPs anymore. They do sort of steam and lasers and all sorts of other things. So prostate would be one. Joints, I think, is fantastic. So that's offering huge, not just for arthritis, for things like tennis elbows and frozen shoulders, where the Japanese are leading the way there. And a big one is oncology. So it blows my mind in South Africa, if you can't burn it and you can't sort of radiate it and you can't poison it, you die. And we've got this whole sort of 25% opportunity to offer people a range of procedures in oncology, and they may be ablations or chemo direct into the tumor. We can offer a range of therapies. It takes a long time and a strong network to do it. So places that have had interventional radiology for years in private, they just don't do enough cases. And so we need to kind of center these cases in specific areas. So I love the oncology space. And I think it's dynamic.
What types of cancers would you typically treat?
So a common one would be a hepatocellular carcinoma. And the Japanese are just far ahead. It's extremely common, I think. What would you say in underdiagnosis in our population? I mean,
I think Chris.
Sorry, the question is
HCCs. Do you think they're underdiagnosed in?
Oh yeah, very much so. I mean, the problem with the HCCs in sub-Saharan Africa is, putting out a screening process, but you've got to have some form of therapy. It's no use picking them up and then saying, well, so look, there are big moves going, big guidelines being published. There is a momentum, and certainly this would be a very viable, together with the radiofrequency ablation and alcohol injection would be very viable. But look, there's been a lot of progress in the treatment of HCC in sub-Saharan Africa, surgical progress, but this definitely would have a great potential. It's just a matter of having the radiology available. That's
exactly it. So we've got this procedure where we can put chemo directly into the tumor. So it's non-curative, but it buys options. Patient could be transplantable, or they may be able to pick and choose lesions. So it gives a whole lot of options, but it just, we're doing a tiny number of cases compared to what they do overseas, and it's paid for and available. And for me, it's just, why aren't the radiologists in the hepato centers offering this?
Well, it's not so much the radiologists. Are you collaborating with the hepatologists?
Yeah,
I mean, Bilal Bobat would be the person to speak.
Yeah, so those are super exciting. I mean, the way we're doing it now is the old way. So it's the Japanese invented a method where you add poppy oil, Lepardol to doxorubicin, and you make this sort of looks like strawberry milkshake. and you give unbelievably high doses, and this tumor like shrinks in weeks. It's exquisite, and you see it the way they do it. And you think, my word, why? There's no reason why we can't.
Maybe a strange question, but I mean, you're injecting all sorts of things there, chemo, poppy oil. Can you do, while you're at it, you've got so much ischemic pain, can one inject any kind of local painkillers into the lesion?
Yeah, you can. It doesn't work though. I tried that. Tried lignocaine 2%, and we found no improvements in our. Well, what you got is you got like a lot of flow through the organ still, so it's not completely. There's still blood passing through, and I think that little dose of a local just becomes, diluted.
Sure. Well, this was truly a unique patient blood management presentation, and Gary, you've opened up some new thinking for all of us. As a matter of fact, Freddie Kabambi and I were working on the WHO strategic plan for low-income countries this afternoon, and interventional radiology was deleted for low-income countries. And I said to him, no. You must come and listen to Gary today. We're going to keep that one because there are ways and ways. And
Absolutely.
so it was put back in with what you're doing in mind, and will hopefully become part of the WHO strategic framework that will be rolled out across the world later this year or beginning of next year. So very, very excited to have met you, to have had you today, and we're certainly going to get you to talk at other events as well.
Thanks. Could I request something from my side? Just what's in it for me is someone on the group commit to reviewing our protocol for in-hospital management of anemia. We could really ramp that up.
100%. Definitely. We definitely have people that can help work on that. Yes, for sure. So with that, thank you, Gary. Thank you again to the University of New Mexico ECHO team, the ECHO India team. A reminder to everyone that the recordings of the talks every week are available on the Gastro Foundation website. Please send your friends there to go and listen to this. And with that, also a special word of thanks to the Gastro Foundation, to Chris Kassianides, who's the father behind all of that, and to our sponsors. Next week, I believe, will be inflammatory bowel disease and not pathology as initially planned. Am I right, Chris?
No, it's actually inflammatory bowel disease as initially planned.
Oh, it is inflammatory bowel disease as initially planned. And yes, and we look forward to seeing all of you back in about 2 months for the next PBM session. But for the other gastro type sessions, it will be every week as usual. Thank you very much, and have a lovely evening and afternoon, everybody. Thanks, Gary. Thanks, Chris. Thanks Cheryl.
Thanks, Gary. Excellent.
Thank you. Thanks.